So I think we'll get this session started for the breakout. And as mentioned before, so my topic actually is very near and dear to my heart, and I know it's very near and dear to a lot of you who have myeloma. What I wanted to first start out with is tell a little story. So we became very interested in pain and pain management in myeloma because we noticed that a lot of our patients needed opioid therapies, so things like morphine, Dilaudid, a lot of these high-risk medications. So we started out actually by looking at our patient population at the University of Illinois, and we wanted to understand how were patients using these medicines throughout their disease trajectory, and did it have a negative impact in the long run? And what we actually found, keeping in mind this was a retrospective study, so we had to go back and dive through charts, and it sort of provided the first signal for us to proceed further research, and luckily with HealthTree. So we found actually that when we looked at patients with myeloma who used opioids for 6 months or longer, even despite being in remission, those patients, when we adjusted for high-risk disease features, prior lines of therapy, those patients who were still on these opioid medicines 6 months after their diagnosis appeared to have inferior survival. And so we were very interested in the why behind that. And with the restrictions of retrospective study, you can't really dive in and ask more questions because you're limited with the data that you have. And so we partnered with HealthTree. We were very lucky to partner with HealthTree along with one of my close friends and colleagues at Emory, Dr. Craig Hoffmeister, where we were able to launch a survey on their portal to ask patients exactly the questions we wanted to ask and get that real world data that we weren't able to through retrospective analyses. So I kind of want to just throw out a question first. Is how many of you here who have myeloma have experienced pain at one point in your disease trajectory? Raise your hand. Yep, so many of you, right? How many of you had to take medicines that belong to the class of the opioid drugs, things like morphine, Dilaudid, Vicodin, Norco? Many of you. Okay. So I think that's an important topic. I think this is, we talk about all these immunotherapies. We talk about, when you're diagnosed, it's sort of tunnel vision, right? You will do anything to focus on the disease and really making that disease go away, both as providers, clinicians, pharmacists, and as patients. And we sort of push all these other things to the side, things like pain. I'm going to come talk to my doctor today, but I want to know, how's my disease? Am I in remission? And sometimes we neglect to talk about very important topics like pain. So I wanted to dive into this research. I thought it was really important. We were able to present this at ASH, which is our annual conference that happens yearly in December. It was actually an oral abstract that was presented at one of the outcomes research series. And I thought it was a great opportunity. Why would not share this exact data and what we found using HealthTree with the patients who are the ones taking these surveys and who we are learning a lot from. So I love that the audience is patients and patient caregivers and patient advocates, because I think knowing what we gained from this project is really important in terms of how could we move to next steps. I'm going to try to not have any snafus with this pointer. So let's see. Okay. So I like to show this figure because you've heard now in several of these talks that, in Dr. Gert's talk and in Dr. Ataya's talk, you saw that there's this expected myeloma disease trajectory, right? That we all have seen, these types of figures where there's these precursor diseases, and then you have active myeloma where the burden is the highest, and then periods of remission where we expect the disease to be at its lowest. For example, when, like Dr. Zoka talked about, it's at the deepest level of remission with MRD negativity. We automatically assume sometimes that pain follows that trajectory. So meaning it's very linear. As the disease burden of myeloma goes up, pain goes up. As the disease burden of myeloma goes down, pain goes down. That's not the truth, though. Pain is very complex. it's very multidimensional. While we know it's very visceral, there are many elements that can contribute to pain. Even things like psychiatric disorders, even things like what we just talked about in Dr. Azoka's talk, social elements that can contribute to access of pain medicines, or the understanding of how to portray pain in the best way possible to our provider team. So it's not, in fact, linear at all. And you can see that disease burden doesn't translate into, the improvement in disease burden doesn't necessarily translate into improvement of pain. And that's why we were really interested in taking a deeper dive into understanding what are these contributors to pain, ongoing pain persistence, and opioid use. So as you know, some of these medicines that I've already discussed, morphine, Dilaudid, a lot of these opioid analgesics, we know that they're critical as adjunctive therapies for the treatment of myeloma bone pain. So many times when you first present with the myeloma and you're admitted to the hospital, for example, with a bone fracture, many physicians will manage the pain with some of these medicines. And what ends up happening is you continue these as the pain gets better, we try to taper them down, but many times these pain medicines continue even on during remission therapy. The problem is that we know, we've gone through several public health crises where we know these medications aren't without risk, specifically addiction risk. So the overuse of these medicines has really been associated with opioid misuse and addiction. And this is the data that I show on the bottom that was from our single center retrospective study, where you can see there's a separation in those two lines, those patients who still were using opioid use long-term versus those who weren't, that there's a separation in the overall survival curve. Keep in mind, this was a retrospective study, so there are many caveats to these curves, but when we, at least with the confines of a retrospective study, adjusted for many factors that we think could contribute to survival, we still found that it emerged as a significant predictor of survival in our patients. So we really wanted to take this beyond our retrospective study. And you've heard about these clinical trials that I think every patient should have the opportunity to learn about clinical trials and have access to clinical trials. But clinical trials are also very highly structured and controlled. And one of the ways that we assess pain is through these, what we call PROs, or patient-reported outcome tools, that I think now have become very prevalent, especially in some of these more recent trials using bispecifics and CAR-T, because it helps us understand not only the objective response, but how is the patient feeling? How is their quality of life? How is that changing dynamically with these treatments? And those also have limitations. They're not the perfect tools, as we know. So we really wanted to find a platform to determine in more granularity patterns of pain in myeloma and patterns of opioid use in a large cohort of myeloma patients, with really critical insight into patient insights, patient's perspective. And that's kind of the real world part of it that we really wanted to take advantage of. So like I said, we partnered with HealthTree and we launched a prospectively administered, what seems to be long, a 31-question survey. We actually, at the University of Illinois, worked with many of our qualitative researchers who have experience with instrument development and really making sure that we are asking the questions in a way that we could get good output from the data. And this was fielded for about a little bit over a year on this online platform. And so you can see this is sort of a breakdown of just baseline demographics of the patients who took the survey. So you can see it was open to all patients who have access, but the majority did have multiple myeloma. Most of them, had a graduate degree, college degree, or some associate's degree. So in terms of background, many of them were insured, had a heterogeneous population, as you can see. So we first wanted to focus on pain and then get into the category of opioids. And I like these figures because I think they're easy to follow. As you can see, we saw, as expected, pain in myeloma is frequent. And mostly patients report it to be moderate to severe in intensity. And most patients attribute it to either the disease itself or the treatment that they're receiving for the myeloma. What I thought was interesting, if you look at that bottom figure, 40% of patients didn't actually know where their pain was coming from. So they either answered other and mentioned several things that weren't necessarily related to the disease or the treatment, or they just said, I don't know what my myeloma, what my pain is from, which we thought was interesting. And then when we look at subsequent sequelae from having pain, you could see that it impacts a lot of other facets of life, including mood. It can cause sleep disturbances and relationship with others. So that was in a third of patients. They were reporting that having this moderate to severe, almost daily pain was affecting their relationship with others in their lives. And then we wanted to figure out, okay, well, when your doctor told you you were in remission, or you were during periods of remission, as defined by your physician, did they still experience pain? And I thought this was really interesting. 50% of patients continue to experience ongoing pain even when they're in remission by their doctor. This just proves to you how myeloma is very different to other diseases, because patients can be left with pain that is a result of the treatment that they received. They can get medicines that are specifically to improve bone growth, but they could still have bone pain ongoing and long-term. It just proves that, again, it's not a linear process, and trying to understand where that pain is coming from and why it still persists in the severity it persists is super important. We then wanted to follow patient attitudes towards the advocacy of pain discussion and management by the oncology team. So a very common theme among all these talks is, as a patient, take control of your disease and take control of these, of what you are expected to know in terms of the disease and what you want out of the treatment. And I think it's really important to understand, well, how is communication? We're all at fault in a busy clinic where there's certain days as a pharmacist, I'll spend an hour with a patient, and then the next time, because of the infrastructure that we're all sort of, under, it could be that I only have 15 minutes with the patient. And that could really dictate the quality of the communication that we have with patients, but it also can really, on the receiving end of the patient, if they're noticing this patient, the clinic looks busy, I have to get to the infusion center then to start my infusion, and I need to finish by 5 p.m. And it sort of is this like downward effect. It decreases the quality of the communication with the healthcare team. And so there's always room to improve when it comes to building an infrastructure in the outpatient clinic where we can have these really high quality, adequate communications with patients. But you can see 40% of patients indicated they rarely or never discussed pain with their oncology care team. That's shocking in a disease where pain is the #1 symptom that these patients are experiencing. And then 30% of patients believed that it was inadequately managed. So again, we have this like tunnel vision, right? We're going to come and see our doctor once a month or once every 3 months, and we're going to talk about where is my myeloma right now, and maybe not focus as much on some of these other peripheral topics that are still very important. Now, what I find interesting is if you're at an academic center or a bigger hospital, most centers now, even private care hospitals, have other services available. For example, palliative care teams, which tend to be multidisciplinary. They usually have a physician, a nurse, a pharmacist, that sort of can contribute to the overall management of the patient. And I know at UIC in particular, they tend to sit with us in the clinic, and we could just as easily just turn around and say, hey, I have a patient who has been on these medicines for a while, and they're still reporting a 9 out of 10. Could you help us with the pain management? It may not be as easy at most centers where they have that type of access to palliative care, but we wanted to find out in how many cases are more specialized teams involved in the overall management of pain. And again, I thought this was interesting that in what we know is a very highly complex and specialized disease like myeloma, oncology-focused consults like palliative care or hospice, which I know a lot of patients, when we mention hospice, have this connotation of is my disease at the end of the road? Is it, very progressed that I need to see hospice? But actually, we can utilize hospice services to help us with these complex pain issues in patients. But we found that they're largely underutilized. And what I thought was interesting is that 30% of patients had a primary care physician that was involved in their pain management, which is fine. But I think sometimes there is a disconnect between what is happening in your oncology care versus what is happening in your day-to-day hypertension management care, or your gen med care that happens once every year, or maybe even less common. There might not be as a readily available conduit between the oncology team and these primary care physicians. Also, at the end of the day, it's not somebody who specializes in analgesia and pain medicine and these myeloma disease itself. So I thought that it was interesting that we really do underutilize these services, and finding ways to implement them up front from the day of diagnosis and then throughout treatment is something that we really need to explore more options for. Now, when we talk about communication with the healthcare team, we found that sometimes there's misrepresentation of pain. And when you get down to it, it makes sense that it could result from patient fears that are rooted in fears of what the implications will be on the treatment, what the implications will be on what does this mean for my disease? If my pain is getting worse, am I progressing, right? That's probably the first thing you think of. But also this feeling of, I don't want to feel like a bother, quote unquote bother, or feel being ignored, feel of being judged or labeled as addicted, especially when it comes to these medicines, right? That you are sort of afraid to bring it up because you don't want to sort of have that label like, oh, they're just here to seek morphine, right? But that's not the case. So there is that ingrown fear too, because of everything that we've been exposed to in the media and what's happened over the years in the opioid world. So we found that a fourth of patients indicated they have intentionally understated their pain, so 25% of patients. And patients understated their pain due to fear of having to start new treatment. That was 30% of the patients. Or because they felt like their doctor, because they did not feel like their doctor listened to them well when describing pain. So again, there seems to be some misrepresentation of pain, which I think is really important to dive into. And I sort of took some of these, it allowed for some free text, which I like in these surveys, because the way you ask the question may not sometimes necessarily give you the opportunity to answer the way you want to answer it. And so patients gave us all kinds of responses that I thought were really interesting. And I put them in red to highlight some of the comments. Bothering the doctor, man up, family doesn't know the extent of the disease, and the extent of pain and appointments. Stating my true pain and mobility issues would probably make me fail the exam, and I certainly would lose the job I love. So it really starts to get at a lot of different issues that could be overlapping at the same time that these patients are experiencing pain. I have had big problems trying to get prescriptions filled because the feds have cut opioid supplies. So it's again, very multidimensional. You start to learn, okay, well, there's things like social elements, financial elements, fear of regulatory elements. What does this mean for my disease? So this is my point, is that it's, as I said, not linear at all, but also there's just so much that contributes to how patients report their pain. So when we learned a lot about the pain, we wanted to then set a series of questions related to opioid medicines. And we were very fortunate that we used a well-known tool that's sort of existed since 2005. A lot of primary care physicians use this tool at baseline to determine an individual's risk for opioid misuse. And you could see it's based on all these factors that could be a little sensitive to ask, but we prefaced that in the survey that you could opt out of answering these questions. Obviously, all of this is confidential, but that it would be sort of used to come up with a score for everyone who completed the survey, and that score then translates into what an individual's baseline opioid risk would be expected to be. Again, this is just one way to do this. Obviously, we know there's better, more comprehensive ways, but this is a common tool that's used in clinic. It's called the Opioid Risk Tool. And you could see that when we added up all the different risk factors and calculated the quote unquote score that the patient has, a score of 3 or lower is low risk, 4 to 7 is sort of somewhere in the middle, it's moderate risk, and a score of 8 or higher is considered to be high risk. So in those who did finish this part of the survey, we found that 70% of patients were considered low risk based on their responses, and about 30% were found to be anywhere between moderate to high risk for potentially opioid misuse. So we took that on to ask a little bit more questions about use of opioids. And again, you can see that over 75% of patients indicated that they had taken an opioid for pain, the majority of which had actually started it after their myeloma diagnosis. So 79% of patients started these opioids after they were diagnosed with myeloma. And then when we start looking at these risk groups, we found that patients who were identified as moderate to high risk based on the opioid risk tool that we administered, more of those patients had indicated that they had taken an opioid for pain compared to those who have low opioid risk. So this now introduces like sort of another element of, consideration when approaching patients about pain. Just looking at baseline risk factors for potentially if these patients are exposed to long-term opioids, what could that mean in terms of dependency? And then related to the question when we asked about when you're in periods of remission, did you still have pain? We found that the use of opioids still persisted, actually in a considerable number of patients, despite being told that they were in remission. So we found that almost over 20% of patients continue to use opioids during remission. Which again begs many questions, I think, is, well, what does that remission look like? What kind of pain were they still, suffering from? How is that pain being treated? It just sort of leads to this trickle-down effect of needing to know a little bit more about the complexity of pain. And again, when we look at those risk groups, we found that more patients who, again, based on that opioid risk tool, who identified as moderate to high risk, used opioids during remission, which I thought was very interesting. So then we asked about patient attitudes towards education. So again, going back to the communication piece, many times, again, we prescribe these opioids and these medicines, and it's sort of like a reflux, right? We're going to refill your morphine. We're going to refill this prescription. There may not be such a detailed assessment and discussion about indication, the continued need for these medications, but also, as Dr. Zoka alluded to with drug therapy, just like in myeloma, and a lot of these drugs we give in myeloma, every patient responds differently to opioid medicines. I've had patients where I was so limited with how much medicine we could give because they would develop side effects. And so, not only in terms of efficacy and toxicity of these medicines, that patients can respond very differently. So that goes to the pain threshold and the opioid threshold that sort of goes up and down based on each individual patient. But you can see 94% had indicated that their prescriber never declined to prescribe opioids, and that in half of these patients, 55% of patients had never had a discussion about stopping these medicines, and 35% indicated that they were not educated on the opioids by their oncology provider team. So again, these patients with myeloma can have renal failure, right, where their kidneys don't work as well as normal patients. We know that the age of myeloma is older usually. So those are two risk factors for vulnerabilities from these medicines and accumulating, not clearing these drugs as well, and potentially having side effects. So how to use these medications safely is really important. And then I wanted to ask a question about, opioids aren't the only pain medicines that are available We have non-pharmacologic strategies. We have other drugs that are very effective against pain, especially specific types of pain in myeloma. And you can see that despite 40% of patients attributing their pain due to treatment side effects, so the one that stands out the most and is the one that most patients actually indicated is the reason for pain was developing neuropathy from drugs like bortezomib, which, 30 to 40% of patients develop neuropathy from bortezomib, and it does depend on, the number of times it's being administered during the week, the cumulative dosing, the baseline disease states of the patient if they had diabetes in the past. Many things can contribute, but even after you stop Velcade and the patient has developed neuropathy, it may still continue to improve after stopping the drug, but what you're left with around 10 months may be what you're left with for life. So I've had patients get transplant and they're on these newer therapies and many, many years later, they're still suffering from these neuropathies. And we know that more than even opioids, which opioids work very well for neuropathy, there are other drugs that tend to be more focused and geared in terms of mechanism of action towards peripheral neuropathy. And so we found that there was underutilization of these other opioid sparing type strategies. But we also found that the prescriber was giving other types of medicines. A follow-up to this survey, which also I thought was very interesting, when we did this, we actually had two surveys in parallel. This one was focused on opioids and pain. The second survey was focused on cannabis use in myeloma. And I know at our institution, patients are using cannabis in all types of ways, topical, systemic, all different formulations, edibles, et cetera. And I have some patients who swear by it and say, this has helped me a lot with my peripheral neuropathy, and some who say it didn't work at all. Again, owing to this interpatient variability in response to these medicines. So I'm very interested in the topic of cannabis in myeloma and its use, and we're trying to pursue further research around cannabis and the types of products that patients are using. But again, drugs that I think would be geared more towards neuropathy, antidepressants, drugs that are traditionally marketed as antidepressants are very helpful against the neuropathy, anticonvulsants as well. Again, it's just not as common. I thought it was interesting that 50% of patients said they were being prescribed something like Tylenol, which is sort of on the opposite end of the spectrum. Again, Tylenol may work in many patients, but based on the number of respondents and the severity of pain that was described in this survey, I was a little interested in how Tylenol, again, because we are very limited. We tend to shy away from NSAIDs because of the kidney function in our patients, the platelets, et cetera, and because of the apprehension around opioids, we may also not go towards opioids. So Tylenol is another alternative, but how efficacious it is really, I think a lot of clinicians will tell you different things. Most of them may laugh and say, no, Tylenol doesn't work for myeloma bone pain. What are you talking about? Now, the last piece of this, which we really wanted to root these questions based on the data that we found at UIC. When a patient undergoes autologous stem cell transplant, there is a lot of things that happen acutely that can contribute to pain. So when you get this high-dose chemotherapy in the hospital or in the clinic, one of the main side effects that we talk about that can happen is something called mucositis. And so this can present, patients can have oral pain, it could sort of present throughout the whole alimentary tract. They can have diarrhea. They're having intravascular lines placed to get collected. That could cause local pain. Actually, what I found very interesting is patients come into the hospital. So at our institution, they get admitted. And because they're laying in bed and they don't have a lot to focus on other than what is happening in the now, we noticed that we start to hear more about the neuropathy, that, I'm noticing that it's worse. And maybe because they're paying attention to it more, And, there's some data that melphalan may exacerbate it a little bit, right? But I always find that I'm having to maybe modify the regimen for their neuropathy while they're in the hospital, because again, we seem to be focusing on it more. It becomes very transparent when, if they're out in the community, they're busy, especially at UIC. We have patients who have to take 3 buses to get to their, healthcare system, to get to the clinic, and they may just be ignoring their symptoms and not necessarily paying attention to it. So I always find it interesting that a couple of days after melphalan, we always hear, "Hey, I'm starting to feel more numbness in my feet and my hands," and I think it's very interesting. We're actually trying to accumulate all that data to look at it in our patient population. But so anyway, my point is we wanted to look at opioid use around the time of transplant. And so what we found is we looked at pre, during, and post-transplant, and we found that 40% of patients were taking an opioid prior to receiving a transplant. 15% become new users, meaning they started opioids for the first time during the hospital. And among those new users, 50% were discharged on opioids, and almost 30% continued them for more than 3 months. So there seems to be a pattern of ongoing prescribing of these medicines. Again, presumably this acute regimen-related toxicity should resolve, right? That's what we would expect. But again, it's not always linear, proving the point that why are we still seeing persistence of, especially in these new users who didn't even need it in the beginning of their disease for bone pain or for neuropathy. So we came up with a lot of conclusions that I think were really important and crucial. So this was, to our knowledge, the largest prospective survey that addressed pain and opioids in myeloma. So pain is one of the most common symptoms in myeloma, but one of the most understudied phenomenons. Understudied, I call it a disease state because in its own, it's a disease state. One of the most understudied disease states in myeloma. And so I think this was a really important study to address opioids and pain in myeloma. We found that pain is frequent even during periods of remission, and it really impacted quality of life negatively. Most reported a history of opioid use, in particular, highly prevalent beginning after their diagnosis, and then ongoing during disease remission, especially those patients who were categorized as moderate to high risk for opioid misuse. Transplant represents a time that introduces opioids to several new users, and this in turn can lead to prolonged use. And based on our data, we show that prolonged use, independent of bony disease and the cytogenetics of the disease, is associated with inferior outcomes. Inadequate pain management can be attributed to either poor communication with the oncology team, which is a great opportunity for us to reassess and use PRO tools in the clinic. I know several groups are doing this as we speak prospectively. But it could also be related to patient understatement of pain, and finally, frequent in-consultation of these specialized pain care services. And then because over half of patients in our cohort had never had a discussion about stopping these drugs, it really highlights an opportunity to reduce opioid-related side effects. And then finally, early palliative care engagement, use of non-opioids, as I mentioned before, and implementing opioid risk in the clinic as part of some of these PRO tools can really globally potentially reduce opioid use where unnecessary. Okay, and I think that's the key term, is where it's unnecessary, because it may be necessary in many patients, right? As we speak of this disease trajectory and how it changes dynamically among patients. So this just briefly gives you an idea of all the awesome people that went into putting this together. We were really fortunate to work with HealthTree, and hopefully can continue this collaboration and try to dive more into some of these observations that we found.